Next, we'll invite the person who was working on Erdheim-Chester disease even before I was in med school. And I think he still looks the same how he did back then. So Julien Haroche needs no introduction. He's going to talk about RDD, clinical molecular characteristics and treatment response from a retrospective cohort of 107 patients. Julien.
Thank you. So hi again. So I'm going to present this series. Actually, it was the work was done by Paul-Marie Suret, who's a resident, and Mathias Papot, who's a fellow, and many other doctors, including Jean-François Emile for the pathologic aspects. So for me and for many others, Rosai-Dorfman-Destombes is more like a syndrome than a disease because it's very heterogeneous. And this is the image taken from the first publication by Destombes, who reported 4 initial cases in 1965 among black children or adolescents. And you can see the major bulky lymph node. And then the name that was used was to describe the disease was after the publication of Rosai and Dorfman in 1969. And so you need to have these images of lymphocytes, nuclei of lymphocyte within histiocytes, and it's an image emperipolesis which is almost pathognomonic of Rosai-Dorfman. But you still have a few differential diagnoses, and you can have a diagnosis of Rosai-Dorfman without emperipolesis. So it's very heterogeneous, and this is from the literature, from this review by Usama and others, which is more like an expert opinion than a consensus guidelines, which was published 6-7 years ago. And so the typical involvement are bilateral major lymph nodes, which are sometimes bulky. You can have lymph node almost everywhere, and the extranodal involvement is usually more severe, and like virtually every organ can be affected. There is also 10-15% of the patients who have autoimmunity, inflammatory syndrome with sometimes CRP getting as high as 300 milligrams per liter. You have hypergammaglobulinemia, and you have also some anemic, some autoimmune, some hemolytic anemia sometimes. So it's been described many associations. The first of all is overt histiocytosis, mainly Erdheim-Chester disease, as we'll see, IgG4-related disease, many autoimmune conditions, like many autoimmune diseases, but also autoimmunity without characterized autoimmune disease, cancers and hemopathy, and there is also a genetic syndrome called H syndrome, which we decided to pull out of this series, and there is a mutation in SLC29A3. So back to this blood publication in 2018, you see that at that time, about 2/3 of the patient, which in the vast majority of the cases could have a phospho-ERK immunostaining. We didn't know where the mutation was. And so there is, the mutation that were found were mainly MAP2K1 and KRAS. And the main message also is that BRAF is never found in Rosai-Dorfman, or almost never found. So in terms of treatment at that time, there was only a small case series. So this is the first description 60 years ago. Some publications said like surgery could be helpful, especially when you had bulky localization. Wait and see, abstention. And I want to point out the fact that if you do not do anything and you have high CRP, there are at least 5-6 cases, including our series and some very nice publication like this one of colleagues from Toulouse. You can develop AA amyloidosis. then you can try methotrexate plus or minus steroids, or cladribine, vinblastine by analogy with other histiocytosis, and of course MEK inhibitors. And rituximab, which is preferred when you have hemolytic anemia or ITP. So you see there is no consensus at all. So we decided to include all cases of RDD patients that were seen over a period of 20 years in our institution, adult patients with a clear histology of RDD. So we reviewed clinical morphological parameters, CRP, blood count, and serum IgG4, and various autoantibodies. We went back to the histological description and molecular analysis, and we screened for associated conditions that are listed here. And for the treatment, we assessed the PERSIST criteria at 6 months, and also particularly for CNS manifestation, the RANO criteria at 6 months. So we were able to find 158 medical records, and we excluded 45 for excessive missing data, which is extremely depressing, and 6 for H syndrome. So we analyzed 107 patients, which were rather old for Rosai-Dorfman, so 44 years old, 40% of female, and quite a lot of general symptoms with fever and weight loss in 10% or more of cases. So some of the images, first, lymphadenopathy was found in 2/3 of the patient, mainly cervical, but also other involvement. You can see that there is almost never splenomegaly in this series. Bone involvement is present in 1/2 of the patient, and you can have lytic and sclerosis or non-specified. 1/3 of patients have skin involvement, which are mainly nodules and papules. Xanthelasma, I think, are due to overt ECD. So you have also meningeal infiltration, which are the one you can see here in these slides, and other involvement of the central nervous system. For diabetes insipidus, I think it's obvious from this slide that this 1 or 2 cases are, again, overt ECD patient, because you don't have, with the sole RDD, you don't have any usually involvement of the hypothalamic axis. ENT patients, ENT involvement was almost 1/2 of the patients, with also orbital involvement and salivary gland. Also eye involvement, so I didn't show you pictures of everything. And you can have also quite a numerous percentage of patients with pulmonary involvement and retroperitoneal also. Testicular involvement was also involved, and we had some sole localization of RDD, and obviously the overt RDD plus ECD linked to MAP2K1. So it's a multi-organ disease. In this series, we have a median number of organs, which is 3, which is a little bit lower than the series of almost 1,200 patients with ECD. And you can see from this series, and there is obviously, I think, a bias, that the lymph node, which was the first localization described in 1965, is only present only, I would say, in 4 patients of this series. So getting to histology, most patients had PS100, CD163, and CD68. Phospho-ERK was positive in 70% of cases, but I'm not sure that every histology benefited from the immunostaining. And you can see here that half of the patients of this series had IgG4 plasmocyte immunostaining. So the mutation, so we performed a dedicated NGS and or RNA-seq, and we found a mutation in almost 60% of cases, which was in the vast majority of cases MAP2K1, and we also find 12% of patients with KRAS mutation. We have also other deletion of BRAF. The BRAF, which is positive here, I'm not absolutely convinced. I think it's, I would have to go back to that patient. I think it's maybe the one that we published with the colleagues from Brazil. But so BRAF is never found, I guess, in Seoul, Rosai-Dorfman. So 2/3 of the patient had high CRP. We had 1/3 of the patient with 1/4 with high IgG4. And again, reflecting what I was saying about autoimmunity, 1/3 of patients with anti-nuclear antibody and other antibodies were less frequently found. So in this series, we had 40% of patients with suggestive clinical features of ECD, and sometimes in a very small subset, but I can't give you the number, we had some histology of ECD, either in the same biopsy or in another biopsy. IgG4-related disease was found in 12% of cases, and we had also 9% of cancer and about 8% of autoimmune diseases. So treatment onset in 75% of the cases were MEK inhibitor for 38 and methotrexate and prednisone for 27 patients. But we also had various other treatment, and the main one was cladribine. So here you have the PET responses with, you can see that complete and partial responses were very good with MEK inhibitor, but also with methotrexate and prednisone. Cladribine and Ritux was more deceitful in our series. And when we look at the RANO criteria for CNS involvement, you can see that we had also very good results for MEK inhibitor and methotrexate and prednisone, whereas cladribine didn't really work, or it was mainly a stabilized disease. So for treatment and outcome, we had a median follow-up of 3.5 years, and we had 7 deaths, 1 of AML and 1 at least of neurological progression. And probably the 3 septic shock, I can't tell you if it was due or partly due to patients who had been under methotrexate or cladribine. So for the discussion, also for the molecular aspect, so you can see that 7 years ago we had 2/3 in the literature, 2/3 of the patients with Rosai-Dorfman who had unknown mutation, and now it's more like 40% in our series, and again the 2 more frequent mutations is MAP2K1 and the KRAS mutation are frequently more seen in patients with ENT involvement. So to tell you that it's a frequently multi-organ presentation in our experience, but there is clearly a bias because we are a referral center for rare disease and also in particular for histiocytic disorders and some that are more rare than the LCH, for instance. And there is definitely a bias that I saw like preparing this talk, is we have to, I think, to pull out a certain proportion of these patients who also have ECD, and in particular when they are MAP2K1, So I think the next step would be to try to include the 41 patients that there was too many missing data, with the help of clinical assistant research and Matthias and Paul-Marie to try to increase the series. And there is some additional ongoing molecular studies or immunohistochemistry to test every cases for OCT2, which is a very important marker, as you know, and CSF1R, and also try to identify other mutations. So to conclude, better responses with MEK inhibitor with overall response rate of 75% on PET and 50% on MRI. I advocate for doing methotrexate and prednisone, which can be a first-line option, and even if the response is a little bit less good in terms of overall response rate. And this goes beyond than Rosai-Dorfman, I think, like in ECD and LCH. I wouldn't go necessarily for a MEK inhibitor frontline when you don't have severe involvement. It's just not because you have a mutation that you should propose a targeted therapy. And I agree with Eli, for instance, and I don't remember, and probably Ron also for a case-by-case discussion, and also not, and probably to insist to convince a patient that if he has very little burden of the disease and involvement, he should probably go first for non-targeted therapy. And so rituximab and cladribine are disciple, but in our series we had very little cytopenia, not cytopenia, hemolytic anemia and ITP, which are very responsive to Ritux. So it seems a protein disease with frequent multi-organ involvement in more than 80% of cases, as opposed to the first description, which were only nodal. Half of patients, or even more, have MAP kinase pathway variant, and MEK inhibitors seems the most effective, but methotrexate and prednisone are clearly a first-line suitable options, and I'm ready to take any questions. Thank you.